What is trepanation? Trepanation, also called trepanation or trepanning, is the practice of creating a hole in the skull by drilling, cutting, scraping, or sawing through the bone. The procedure removes a piece of the skull, creating an opening that exposes the membrane covering the brain, though typically not the brain tissue itself. The opening can be small, just a few millimeters across, or quite large, several inches in diameter. The word comes from the Greek trepanon, meaning to bore or drill. Related terms appear in various languages, all referring to this act of piercing the skull. In medical contexts, the modern term is craniotomy, though this typically refers to surgical procedures done with contemporary medical knowledge and techniques, while trepanation often refers to the historical or non-medical practice. The procedure can be performed using various tools and methods. The earliest trepanations were probably done with sharpened stones, scraping away at the skull in a circular pattern until a hole was created. This scraping method is slow and laborious. It might take hours of careful work to penetrate the skull without damaging the brain beneath. But stone tools, properly sharpened and applied with skill, could accomplish the task. Later cultures developed specialized tools for trepanation. Bronze and iron implements allowed for more efficient bone removal. Some cultures created cylindrical saws that could cut circular plugs from the skull. Others used drill-like tools that could bore through the bone. Medieval and Renaissance surgeons had elaborate trepanation sets with various implements for different stages of the procedure: tools to cut the skin, to drill or saw the bone, to smooth edges, to protect brain membranes. The skull consists of several bones fused together, with the cranium, the top and sides of the skull, being the typical target for trepanation. The bone varies in thickness across the skull, generally thicker in some areas, thinner in others. An adult human skull is typically about 6 to 7 millimeters thick, though this varies by location and individual. Penetrating this bone without damaging the brain, blood vessels, or protective membranes requires precision and knowledge of anatomy. Successful trepanation leaves characteristic marks on the skull. The bone around the opening shows signs of healing if the person survived the procedure. New bone growth creates a beveled edge, smooth and rounded, indicating that the person lived weeks, months, or years after the operation. This bone remodeling is how we know that many ancient trepanations were survived. The skull literally bears evidence of healing. Failed trepanations also leave evidence. Skulls with openings but no signs of healing indicate the person died during or shortly after the procedure, before bone could begin to regenerate. Some skulls show multiple trepanation attempts in different locations, suggesting repeated procedures on the same individual. Whether these multiple openings represent treatment of different conditions or repeated attempts to address the same problem, we can only speculate. The survival rates for ancient trepanation were surprisingly high given the lack of modern medical knowledge. Studies of prehistoric skulls with trepanation holes show that perhaps 50 to 70% of procedures were survived, at least long enough for bone healing to begin. This suggests that the practitioners had considerable skill and that their patients were often robust enough to withstand the trauma of having their skulls opened without anesthesia or antibiotics. Welcome. Settle into comfort, let your body relax completely, and prepare for a journey through one of humanity's oldest and strangest medical practices. Tonight, we'll explore trepanation, the deliberate drilling, scraping, or cutting of holes into the human skull while the person is still alive. This is a practice that spans millennia, from the Stone Age to the present day. It's been performed on every continent, in virtually every culture, for reasons ranging from medical necessity to spiritual belief to, in modern times, the pursuit of altered consciousness. It's a story of desperate measures, ancient skill, suffering and survival, and the persistent human belief that opening the skull might cure what ails the mind. Don't worry about following every detail. Let the words flow over you like a gentle tide. If you drift away before the story ends, that's perfectly fine. That's what we're here for. Close your eyes if you'd like, take a deep breath, and let's begin thousands of years ago, when someone first decided that boring a hole in a skull might be a good idea. The discovery of ancient trepanation. The modern discovery that ancient peoples performed trepanation came gradually through archaeological finds in the 19th century. As archaeologists excavated burial sites and examined ancient human remains, they began finding skulls with holes that couldn't be explained by injury or disease. In 1865, a physician named Paul Broca, famous for his work on brain localization, examined a skull from a Peruvian burial site. The skull had a rectangular opening in it, with clear signs of bone healing around the edges. Broca recognized that this opening had been deliberately created and that the person had survived the procedure. This was a revelation. Prehistoric people, without metal tools or medical knowledge as Europeans understood it, had successfully performed brain surgery. The findings sparked intense interest and debate. How had ancient peoples known how to do this? What tools had they used? Why had they done it? What conditions were they trying to treat? Archaeological excavations became more attentive to signs of trepanation, and researchers began finding examples from sites around the world. Peru and Bolivia proved especially rich in trepanned skulls. Pre-Columbian cultures in the Andes, particularly the Inca and their predecessors, had practiced trepanation extensively. Hundreds of skulls with evidence of the procedure have been found. Some individuals had undergone multiple trepanations, with 2, 3, or even more holes in their skulls, all showing signs of healing. These repeated procedures suggest both that patients survived and that whatever condition prompted trepanation was recurring or persistent. European prehistoric sites also yielded trepanned skulls. Neolithic burials in France, dating back 5,000 to 7,000 years, included skulls with scraped openings. Bronze Age and Iron Age sites across Europe showed evidence of the practice continuing for millennia. Each culture seemed to have developed its own techniques and tools, but the basic concept was universal. Opening the skull could serve some purpose worth the considerable risk and suffering involved. Researchers found trepanned skulls in Africa, Asia, and the Pacific Islands. The practice appeared to be nearly universal among human cultures at certain stages of development. This geographic and temporal distribution suggested that trepanation wasn't a bizarre anomaly practiced by one strange culture but rather a logical conclusion that many cultures reached independently when faced with certain medical or spiritual challenges. The skulls told stories. Some showed evidence of head trauma, fractures, or depressed bone, with trepanation performed nearby, suggesting the procedure was treatment for injury. Others showed no obvious pathology, leading to speculation about non-medical reasons for the operations. Some skulls displayed extraordinary skill in the execution: clean edges, precise circles, complete penetration without evident damage to underlying structures. Others were crude, showing hesitation marks, incomplete penetrations, or signs of complications. One particularly fascinating discovery was that the removed skull pieces themselves were sometimes kept. These skull discs, called rondellas, have been found in burials and other archaeological contexts. Some cultures seem to have valued these bone pieces, perhaps as amulets or talismans. The person who underwent trepanation might keep their own skull piece, or it might be given to someone else. The meaning of this practice remains mysterious, but it suggests that the skull opening and the removed bone had significance beyond simple medical procedure. Why did they do it? Understanding why ancient peoples practiced trepanation requires examining the evidence carefully while acknowledging that we can only hypothesize about motivations from thousands of years ago. However, patterns in the archaeological record suggest several likely reasons. Treatment of head trauma appears to be one clear motivation. Many trepanned skulls show evidence of injury, fractures, depressed bone fragments, or other trauma. In these cases, trepanation likely served to relieve pressure on the brain, remove bone fragments, or address complications from the injury. Ancient practitioners may have observed that people with certain types of head injuries improved after trepanation, developing empirical knowledge about when the procedure helped even without understanding the underlying anatomy or physiology. Headaches and seizures were probably common reasons for trepanation in cases where no obvious injury is present. From a pre-scientific perspective, severe chronic headaches or seizure disorders might be understood as something wrong inside the head that needed to be released. Drilling a hole could be seen as providing an escape route for whatever was causing the problem, whether understood as bad humors, evil spirits, or simply pressure that needed relief. Mental illness may have prompted some trepanations. Psychosis, severe depression, mania, or other psychiatric conditions might be interpreted as spiritual possession, invasion by malevolent forces, or physical blockage requiring surgical intervention. If someone's behavior changed dramatically or disturbingly, opening their skull might seem a logical intervention, especially if the procedure occasionally coincided with improvement or remission of symptoms. Ritual or spiritual purposes cannot be ruled out for some trepanations, particularly those showing no evidence of medical necessity. Some cultures may have performed trepanation as initiation rites, status markers, or spiritual practices. The removal of skull bone might be seen as creating an opening for spirits to enter or leave, or as marking someone as specially chosen or transformed. The keeping of skull discs as talismans supports the idea that spiritual significance was attached to the procedure. Pain relief in cases of chronic headache syndromes could explain many trepanations. Migraines, cluster headaches, or other severe head pain conditions would be desperately motivating in eras without pharmaceutical pain relief. If trepanation occasionally provided relief, perhaps by some poorly understood mechanism, or simply through placebo effect, this would be enough to perpetuate the practice. The empirical observation that the procedure sometimes helped would be sufficient to continue it. Ancient peoples weren't foolish or superstitious to the point of repeating obviously useless procedures. If trepanation never helped anyone, if everyone who underwent it died or got worse, the practice would have ceased. The fact that it persisted across cultures and millennia suggests it must have helped sometimes, providing enough positive results to justify the considerable risks and suffering involved. We also cannot discount the possibility that in some cases, people requested trepanation or underwent it voluntarily, believing it would help them. Someone suffering from unbearable head pain, seizures, or mental disturbance might desperately seek any possible relief. If trepanation had a reputation for sometimes helping, sufferers might request the procedure despite knowing the risks. Ancient techniques, the Incan masters. The Andean civilizations of pre-Columbian South America, particularly the Inca and their predecessors, developed trepanation into a sophisticated surgical practice with survival rates that rivaled or exceeded those of European surgeons performing similar procedures in the same time period. Their techniques and skill levels were extraordinary. Incan trepanation primarily used a scraping method. The surgeon would use a sharp obsidian or metal blade to scrape away at the skull in a circular pattern, gradually wearing through the bone layer by layer. This was painstakingly slow work. A single trepanation might take hours of careful scraping. But the method had advantages. It was controlled and precise, with less risk of suddenly plunging through the skull and damaging the brain than cutting or drilling methods presented. The tools were simple but effective. Obsidian, volcanic glass that can be shaped edges sharper than modern steel, made excellent scraping implements. The Inca also used bronze and later copper tools. Some implements were shaped specifically for trepanation, with curved blades designed to scrape circular patterns. Archaeological finds have uncovered surgical kits that appear to have been dedicated to trepanation, suggesting specialist surgeons who performed the procedure repeatedly. The typical Incan trepanation created a roughly square or rectangular opening, though circular holes were also common. The edges were usually beveled, sloping inward, which reduced the total amount of bone that needed to be removed while still creating an adequate opening. This beveling also helped with healing, creating a shape that new bone could fill in more easily than sharp perpendicular edges. Evidence suggests Incan surgeons understood infection risk and took steps to minimize it. Some trepanned skulls show signs that the surgical site was kept clean during healing. Incan medicine included various plant-based antiseptics and wound treatments. While they didn't understand germ theory, empirical observation would have taught them that keeping wounds clean improved outcomes. The survival rates for Incan trepanation were remarkable. Studies of skulls from different time periods show that in early periods, perhaps 40 to 50% of patients survived. But by the Incan period proper, survival rates had increased to perhaps 75 to 80% or even higher. This improvement suggests accumulated knowledge and refined technique passed down through generations of practitioners. Multiple trepanations on single individuals were common in Andean cultures. Some skulls show 3, 4, or even 5 separate trepanation holes, all with evidence of healing. This indicates both that patients survived the procedure well enough to undergo it again and that whatever condition prompted trepanation often recurred. Head trauma from warfare or accidents might explain some multiple trepanations, each new injury requiring another procedure. The Inca and related cultures also practiced cranial deformation, intentionally reshaping infants' skulls by binding them during the plastic phase of bone development. Interestingly, people with deformed skulls seem to have undergone trepanation at similar rates to those with normal skull shapes, suggesting the procedures were unrelated practices. However, some researchers have speculated that deformed skulls might have made trepanation technically more challenging, as the bone thickness and shape would be altered. European Stone Age techniques. While Andean trepanation was highly developed, European cultures also practiced the procedure from prehistoric times, developing their own distinctive methods and achieving their own survival successes and failures. Neolithic Europeans, living 5,000 to 7,000 years ago, performed trepanation using stone tools exclusively. Like the Inca, they primarily employed scraping methods, wearing away the skull gradually until perforation occurred. The circular scraped openings in Neolithic European skulls are remarkably similar to those found in South America, suggesting this was a logical technique that different cultures arrived at independently. Flint and other fine-grained stones could be shaped into extremely sharp scrapers. Archaeological experiments have shown that these stone tools could effectively remove skull bone, though the process was time-consuming and physically demanding for both patient and surgeon. The surgeon would need to maintain focus and control for hours while the patient endured ongoing pain and the sound and sensation of stone scraping against their skull. Some European trepanations used a grooving technique, where the surgeon would scrape several intersecting lines into the skull, creating a cross or asterisk pattern. The bone between the grooves could then be carefully pried out once the grooves were deep enough. This technique might be faster than scraping away the entire circular area but risked breaking off larger chunks of bone unpredictably. Bronze Age Europeans developed metal tools that made trepanation somewhat easier and faster. Bronze scrapers and small saws allowed for more efficient bone removal. However, bronze is relatively soft, and tools would need frequent resharpening during a procedure. Iron Age tools represented further improvement, as iron and later steel held edges better and allowed for more aggressive cutting. The survival evidence from European trepanations is mixed. Some periods and regions show high survival rates comparable to those of the Inca. Others show lower survival rates, with many skulls displaying trepanation openings but no evidence of healing. This variation might reflect differences in surgical skill, in the conditions being treated, in postoperative care, or in the general health of populations undergoing the procedures. Celtic cultures in Western Europe practiced trepanation into the historical period. Written accounts from Greek and Roman authors mention that Celtic healers performed skull surgery, though details are scarce. Archaeological finds confirm that Celtic populations did indeed practice trepanation, with some skulls showing sophisticated technique and excellent survival outcomes. The purpose of European trepanation seems to have been primarily medical rather than ritual, based on the evidence. Most trepanned skulls show signs of head trauma, fractures, or depressed bone, suggesting the procedure was treatment for injury. However, some skulls without obvious trauma have been trepanned, leaving open the possibility of ritual or spiritual purposes in at least some cases. Viking Age Scandinavians also practiced trepanation, though examples are relatively rare. The few Viking-era trepanned skulls that have been found show competent technique, suggesting knowledge of the procedure even if it wasn't performed frequently. Given Viking culture's emphasis on warfare and the head injuries that combat produces, trepanation would have been a useful skill for Viking healers to possess. Pacific Islander and Asian techniques. Trepanation was not limited to Europe and the Americas. Cultures in the Pacific Islands, Asia, and Africa also developed the practice, each with their own techniques and cultural contexts. Melanesian cultures in the South Pacific practiced trepanation using distinctive methods. Some Pacific Island trepanations involved creating multiple small holes in a circular pattern, then breaking out the bone between them to create a larger opening. This technique allowed for careful control. If a single hole was positioned poorly or created problems, the surgeon could stop before completing the full circle. Pacific Islander surgeons used sharpened shells, shark teeth, and volcanic glass as cutting implements. These materials, readily available in island environments, could be shaped to extremely sharp edges suitable for surgical work. The techniques developed were adapted to these materials, scraping and sawing motions that worked well with the tools at hand. In some Pacific cultures, trepanation seems to have been performed primarily or exclusively on warriors who suffered head wounds in combat. The procedure was treatment for depressed skull fractures, where bone fragments were pushed inward toward the brain. By opening the skull near the fracture site, surgeons could remove or reposition bone fragments, relieve pressure, and potentially save lives that would otherwise be lost to traumatic brain injury. Chinese medical texts from ancient periods mention skull surgery, though it's unclear how common trepanation was in Chinese medical practice. Archaeological evidence of trepanation in China is limited, suggesting it may have been a rare procedure or that it was described in texts without being widely practiced. Chinese medicine developed along different theoretical lines than Western medicine, with different understandings of anatomy and disease, which may have made trepanation seem less necessary or desirable. Tibetan medicine included skull surgery in its practices, with some historical accounts describing procedures that sound like trepanation. Buddhist medical texts discuss brain-related conditions and their treatments, some of which involved opening the skull. However, the extent of actual practice versus theoretical description is difficult to determine from available evidence. African trepanation evidence exists but is less extensively documented than that from Europe or the Americas. Some sub-Saharan African cultures practice trepanation, with archaeological finds confirming the procedure occurred. The techniques appear similar to those developed elsewhere, scraping or cutting through bone to create openings. As in other regions, head trauma treatment seems a likely motivation, though other cultural factors may have played roles we cannot now determine. Tools of the trade. Across cultures and time periods, the tools used for trepanation evolved from the simplest sharp stones to sophisticated surgical instrument sets. Examining these tools reveals the ingenuity and skill of ancient surgeons working with limited resources. Stone tools were the earliest trepanation implements. Sharp-edged stones could scrape through bone given enough time and effort. Obsidian, capable of being shaped to extraordinarily sharp edges, was prized where available. Flint, chert, and other fine-grained stones also worked well. These tools were effective but required considerable time. A single trepanation might take 3 to 6 hours of continuous scraping. The introduction of metal tools represented a major advance. Bronze implements could be shaped more precisely than stone, and while softer than steel, bronze held an edge adequate for bone work. Copper, even softer, could still function for scraping if resharpened frequently. The ability to cast metal into specific shapes meant tools could be designed for particular stages of trepanation, cutting skin, scraping bone, smoothing edges. Iron and steel tools made the procedure faster and potentially safer. A good steel blade could cut through bone more quickly than bronze or stone, reducing the time the patient had to endure the surgery. However, faster cutting also increased the risk of accidentally penetrating too deeply, making control and skill more critical than ever. Specialized trepanation tools appeared in various cultures. Bow drills, where a string was wrapped around a drill bit and pulled back and forth to create rotational motion, allowed for drilling rather than just scraping. Crown trepans, cylindrical saws that could cut circular plugs from the skull, appeared in medieval Europe. These tools made trepanation faster but required even greater anatomical knowledge to use safely. The surgeon also needed tools beyond those that cut bone. Instruments to cut and retract the scalp, to clean the surgical site, to protect underlying membranes once bone was penetrated, to control bleeding, all of these were necessary for successful surgery. By medieval times, European surgical manuals described complete trepanation kits with a dozen or more specialized instruments. The procedure, what actually happened? To truly understand trepanation, we must confront what it meant to undergo the procedure in an era without anesthesia, antibiotics, or modern medical knowledge. Let's walk through what a typical ancient trepanation would have involved, acknowledging the suffering while respecting those who endured it. The patient would be positioned carefully, usually seated or lying down with the head supported and immobilized. Keeping the head still was crucial. Any movement during the procedure could result in errors that might prove fatal. In some cultures, assistants would hold the patient's head steady. In others, the patient might be positioned so gravity and supports kept the head stable. The scalp would be shaved if hair covered the surgical site. Then the surgeon would cut through the skin and tissue covering the skull, peeling it back to expose the bone beneath. This initial cutting would be extremely painful. The scalp is rich in nerve endings and blood vessels. Blood would flow freely, as scalp wounds bleed profusely. The surgeon would need to control bleeding enough to see the bone clearly, perhaps using pressure, cautery, or whatever hemostatic methods their culture had developed. Then came the bone work, the long, arduous process of penetrating the skull. If using scraping methods, the surgeon would begin working the tool in circular patterns, gradually wearing through the bone. The patient would feel and hear every stroke, the scraping sound, the pressure, the gradual deepening of the groove being created. This would continue for hours in many cases, the patient fully conscious and aware of what was being done to their skull. The pain would be intense but not necessarily unbearable for the entire procedure. Bone itself has no pain receptors, so once through the initial tissue layers, the patient might feel pressure and vibration more than sharp pain. However, the membranes covering the brain are sensitive, and approaching them would cause significant discomfort. The psychological experience, knowing someone is boring through your skull, hearing and feeling it happening, would be its own form of suffering. Some cultures may have used substances to dull pain or alter consciousness during trepanation. Alcohol, opium where available, various plant-based medicines, these could help patients endure the procedure. Some researchers have suggested that coca leaves in Andean cultures or cannabis in Asian ones might have been used to ease suffering during trepanation. However, complete anesthesia wasn't available, so patients remained at least partially conscious throughout. The patient's consciousness was actually important for the surgeon's work. A patient who could respond, who could indicate if something felt wrong, who remained alert enough to follow instructions, this provided feedback the surgeon needed. If the patient became unconscious or unresponsive during the procedure, this might indicate complications or that the surgeon had penetrated too deeply. As the surgeon approached complete penetration of the skull, special care was required. The inner surface of the skull is irregular, and immediately beneath lies the dura mater, the tough outer membrane protecting the brain. Penetrating this membrane would expose brain tissue itself and greatly increase infection and complication risks. Skilled surgeons could sense when they were close to full penetration, the bone became thinner, the resistance decreased, perhaps the color or texture of bone dust changed. The final breakthrough moment was critical. Some surgeons created a small initial perforation, then carefully enlarged it to the desired size, ensuring they didn't damage underlying structures. Others might remove the bone in sections, creating multiple small openings before joining them into one larger hole. The technique varied, but the goal remained constant, opening the skull without destroying what lay beneath. The patient experience. Imagine being that patient. You're suffering from severe head pain, seizures, or the effects of a traumatic head injury. You've exhausted other remedies. Someone tells you that opening your skull might help, that others have undergone the procedure and survived, even improved. You agree, or perhaps you have no choice, or perhaps your family decides for you. You're positioned where the surgery will occur. Perhaps outdoors in sunlight so the surgeon can see clearly. Perhaps in a dwelling with smoke from a fire stinging your eyes. Perhaps in a temple or healing house with ritual elements accompanying the medical procedure. The setting varies by culture, but the essential experience remains similar across time and place. The surgeon begins. You feel the knife cutting your scalp. The pain is sharp and immediate. Blood runs warm down your face and neck. You're told to stay still, stay calm. Hands hold your head immobile. The surgeon works quickly through this initial stage, cutting and peeling back tissue to expose bone. Then the scraping begins. You hear it more than feel it at first, a rhythmic scraping sound, wet and grating. The tool moves in circles on your skull. Minutes pass. The scraping continues. Your head aches from staying still, from the pressure of the tool, from the ongoing trauma. The sound becomes maddening, scrape, 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 endless and unchanging. An hour passes, perhaps more. The surgeon pauses occasionally to check progress, to clear away bone dust, to wipe blood. Then resumes. The sound and sensation continue. Your scalp throbs. Your neck hurts from holding position. You may be given something to drink, water, perhaps something medicinal. You're encouraged, reassured. The surgeon may tell you it's going well, that you're doing well, that it won't be much longer. The sensation changes as the bone grows thinner. The pressure feels different. The sound alters slightly. The surgeon slows, works more carefully. You might feel a sudden change, a different kind of pressure, a sensation of something giving way. The surgeon has broken through. The opening is complete. Relief mixes with fear. The pain of the procedure is ending, but what comes next? Will this help? Will you survive? Will you be better or worse than before? The surgeon examines the opening, perhaps removes bone fragments or addresses whatever condition prompted the surgery. You feel manipulations, pressure, odd sensations as the surgeon works on or near your brain. Finally, it's done. The opening is created and the immediate surgical work complete. The scalp is repositioned over the wound, perhaps stitched or bound. Bandages are applied. You're helped to a place to rest. The ordeal is over, but recovery is just beginning. The hours and days that follow are critical. Fever might develop, indicating infection. Seizures or changes in consciousness might signal complications. Or you might simply hurt, badly, as the trauma of the surgery takes its toll. Ancient peoples had limited options for managing these post-operative challenges, though they likely had plant-based remedies for pain and perhaps for infection. Some patients recovered relatively quickly. Within weeks, they were up and functioning, the wound healing, bone beginning to regenerate at the edges of the opening. These successful cases would reinforce belief in the procedure, encouraging its continued practice. Others deteriorated, developing complications that led to death days or weeks after surgery. Still others experienced immediate problems during or right after the procedure, dying before postoperative recovery could even begin. Pain, consciousness, and endurance. The question of how patients endured trepanation without anesthesia speaks to both human pain tolerance and the desperate circumstances that made the procedure seem worthwhile despite the suffering involved. Pain tolerance varies significantly among individuals, influenced by physiology, psychology, and cultural factors. Some people naturally experience pain less intensely than others. Cultural expectations and training can also affect how people respond to pain. In societies where enduring suffering stoically was valued, where showing pain was shameful, people might train themselves to withstand greater discomfort without outcry or resistance. The type of pain matters too. Sharp, sudden pain is often harder to endure than steady, ongoing pain. The initial scalp cutting would be intensely painful but brief. The hours of bone scraping would be uncomfortable and disturbing but perhaps less acutely agonizing. The psychological component, fear, anxiety, anticipation, might be as challenging as the physical pain itself. Dissociation and altered states of consciousness sometimes occur during severe pain or trauma. Some patients might have entered trance-like states during trepanation, their consciousness withdrawing from the immediate physical experience. This dissociation could be spontaneous or potentially facilitated by ritual elements if trepanation was performed in ceremonial contexts. The patient's motivation affected their ability to endure. Someone suffering from unbearable chronic headaches might be willing to endure trepanation's pain for chance of relief. A warrior with a depressed skull fracture causing seizures and disability might prefer the risks of surgery to continued suffering. When the alternative to surgery is ongoing agony or death, the pain of trepanation becomes more bearable. Social support during the procedure probably mattered significantly. Having family members present, having a respected healer performing the surgery, having community members offering encouragement, all of this could help patients endure. The social meaning of the procedure, whether it was seen as healing, spiritual transformation, or warrior's ordeal, would frame the experience and affect how bearable it seemed. Physical restraint was probably used in some cases, particularly if patients were children or were too distressed to cooperate. Being held down during the procedure would add terror to pain, making the experience even more traumatic. However, some level of patient cooperation was necessary. Thrashing or fighting would make the surgery impossible or dangerous. Most patients probably submitted as voluntarily as possible under the circumstances. The duration of ancient trepanations, often several hours, tested endurance in ways that briefer procedures wouldn't. Anyone can endure intense pain for minutes. Enduring hours of ongoing discomfort and distress requires different reserves of strength. Patients might reach breaking points where they begged for the procedure to stop, where they could no longer maintain stillness, where their consciousness began to slip away from exhaustion and trauma. What the surgeon saw. From the surgeon's perspective, trepanation required skill, knowledge, and psychological fortitude. Cutting into someone's skull while they remained conscious, managing their pain and fear while concentrating on precise and dangerous work, was extraordinarily demanding. As the surgeon worked through the skull bone, the appearance and feel of the material changed with depth. The outer layer of skull bone is compact and hard. Deeper lies the diploe, a spongy layer with blood vessels running through it. The inner surface is again compact bone. Skilled surgeons learn to recognize these layers, using changes in resistance and appearance to judge depth and avoid penetrating too far. Blood was a constant presence. The scalp wound bled significantly. The diploe layer of bone contained vessels that bled when cut. The surgeon had to work in blood, wiping it away constantly to see the surgical site. Managing this bleeding while maintaining visibility and control required practiced technique. As the opening neared completion, the surgeon would see the dura mater through the thinning bone, a tough, grayish membrane covering the brain. This was the goal, to open the skull to the dura without penetrating it. Success meant stopping at precisely the right depth, creating an opening without exposing actual brain tissue. If the surgery was for head trauma, the surgeon might see depressed bone fragments, blood clots, or damaged tissue once the opening was created. Removing bone fragments, clearing clots, relieving pressure, these interventions might genuinely help the patient. The surgeon could see immediate evidence of the problem and could take concrete steps to address it. For other conditions, headaches, seizures, mental disturbances, the surgeon might see nothing obviously wrong once the skull was opened. The dura might look normal. No visible pathology would be present. Yet if the patient improved afterward, this would validate the procedure even without visible confirmation of what was being treated. Survival and death. The question of how many people survived ancient trepanation is both fascinating and sobering. The evidence comes from skulls themselves, which tell clear stories about whether the patient lived long enough for bone healing to occur. When someone survives trepanation for more than a few weeks, new bone begins to grow around the edges of the opening. This bone remodeling creates a smooth, beveled edge that's clearly distinguishable from the sharp, raw edges of fresh bone cuts. The longer the person survives, the more extensive this healing becomes. Some skulls show almost complete closure of openings, with new bone nearly filling the hole over months or years. Studies of large collections of trepanned skulls allow researchers to calculate survival rates. They examine the edges of the openings, smooth and healed versus sharp and unhealed, to determine how many patients lived. The results vary by culture, time period, and presumably by the skill of the surgeons performing the procedures. In some Andean populations, survival rates approached 80% or higher. 4 out of 5 people who underwent trepanation lived long enough for healing to begin. This is remarkable for a procedure performed without anesthesia, antibiotics, or modern medical knowledge. It suggests highly skilled surgeons, effective techniques, and perhaps postoperative care that minimized infection and complications. European survival rates were more variable. Some regions and time periods show rates similar to Andean cultures, 60 to 70% survival. Others show much lower rates, with half or fewer patients surviving. This variability might reflect differences in surgical skill, in the conditions being treated, in overall population health, or in cultural practices around postoperative care. The patients who died fell into different categories. Some probably died during the procedure itself, from shock, from blood loss, from accidental damage to blood vessels or brain tissue. Others survived the surgery but died in the hours or days afterward from complications. Still others lived weeks before succumbing to infections or other postoperative problems. Infection was likely the leading cause of postoperative death. Opening the skull creates a direct pathway for bacteria to reach the brain and its protective membranes. Meningitis, brain abscess, or sepsis could develop even if the surgery itself was technically successful. Without antibiotics, these infections were usually fatal. Some cultures may have had plant-based remedies with antimicrobial properties, but these would have been limited in effectiveness. Bleeding complications could also kill patients. While surgeons tried to control bleeding during the procedure, vessels might be damaged in ways that led to later hemorrhage. Blood accumulating inside the skull could create pressure on the brain, causing deterioration and death hours or days after surgery. The surgeon might not even realize the problem existed until it was too late. Seizures occurring during or after trepanation could be dangerous. If the procedure was being performed to treat seizures, this irony would be particularly tragic, the treatment triggering the very problem it was meant to solve. Brain swelling from surgical trauma could also cause problems, creating pressure that led to unconsciousness and death. The patients who survived and healed tell us something important: trepanation could be performed successfully using ancient techniques. The procedure was dangerous but not automatically fatal. Skilled practitioners could open skulls, address whatever condition prompted surgery, and close the wound in ways that allowed healing. This suggests substantial anatomical knowledge and refined technique developed over generations of practice. The healing process. For those who survived the immediate dangers of trepanation, healing was a long and uncertain process. Understanding what recovery would have been like helps us appreciate both the resilience of ancient peoples and the limitations they faced. In the first days after surgery, the patient would be at highest risk for complications. The wound would be painful, swollen, and vulnerable to infection. Fever was probably common as the body's inflammatory response activated. The patient might experience headaches, dizziness, nausea, or confusion from the trauma and swelling. Postoperative care varied by culture but likely included keeping the wound clean and protected. Bandages or dressings would cover the surgical site. These might be changed regularly or left in place until healing advanced. Some cultures may have applied medicinal plants or other substances believed to promote healing or prevent infection. Movement would be limited initially. The patient would need to rest, avoid activities that might jar the head or reopen the wound. Elevation of the head might reduce swelling. Gentle care from family or community members would be necessary, bringing food and water, helping with elimination, providing comfort and reassurance. Pain management would be challenging. Ancient peoples had various analgesic plants, willow bark containing compounds similar to aspirin, opium poppies were available, various other herbs with pain-relieving properties. But the effectiveness of these remedies was limited. Patients would simply have to endure significant discomfort as healing progressed. The scalp wound would begin healing within days, skin edges knitting together and scabs forming. But bone healing was much slower. New bone growth around the trepanation opening would take weeks to become visible, months to create substantial regrowth. In some cases, the opening never fully closed, leaving a permanent hole in the skull covered only by scalp and scar tissue. The appearance of healing bone would have been a good sign to ancient healers. They may not have understood the biological processes involved, but they could see that bone was regenerating, that the body was repairing the damage. This visible evidence of healing would reassure both patient and healer that recovery was progressing. Some patients experienced complete recovery, returning to normal activities with no lasting deficits. These were the best outcomes: the headaches ceased, the seizures stopped, the head injury effects resolved, and the person returned to their previous state of health. These successful cases would be remembered and celebrated, encouraging others to undergo trepanation when faced with similar conditions. Other patients survived but with lasting problems. They might have chronic pain at the surgical site. Weakness or paralysis could develop if brain tissue was damaged during surgery. Personality changes, memory problems, or cognitive deficits might occur. The protective bone covering for the brain was now missing or reduced, leaving vulnerability to future head trauma. These partial successes were still better than death but demonstrated the procedure's risks and limitations. The psychological recovery was its own challenge. Having undergone such an extreme procedure, having survived trauma that killed others, having a permanent opening in one's skull, all of this would affect how the person thought about themselves and how others viewed them. In some cultures, surviving trepanation might confer status or mark someone as special. In others, it might be seen as weakness or damage. Famous archaeological examples. Certain trepan skulls discovered by archaeologists have become famous either because of their extraordinary features, their historical importance, or what they reveal about ancient surgical practices. One of the most remarkable examples comes from Peru, a skull with 7 separate trepanation holes, all showing evidence of healing. This individual underwent the procedure 7 times and survived all 7, living long enough after each for bone healing to occur. The locations of the holes suggest treatment of multiple head injuries, perhaps sustained over years of warfare or accidents. This skull demonstrates both the skill of Incan surgeons and the remarkable resilience of their patient. Another extraordinary Peruvian skull shows a massive trepanation opening covering a significant portion of the cranial vault. The hole is roughly rectangular and measures several inches across. Yet the edges show clear healing, indicating the person survived having an enormous section of skull removed. How they survived such extensive surgery, how they managed with so little protective bone remaining, remains almost miraculous even understanding ancient surgical techniques. A Neolithic skull from France, dating to about 6,500 years ago, represents one of the earliest clear examples of successful trepanation. The circular opening shows meticulous scraping technique and complete bone healing. This skull proves that extremely ancient peoples possessed both the knowledge and skill to perform successful brain surgery, challenging assumptions about prehistoric capabilities. A Bronze Age skull from England shows evidence of trepanation performed on someone who was already elderly, perhaps 50 or 60 years old, ancient for Bronze Age peoples. The healing pattern suggests they survived the procedure and lived at least several months afterward. This demonstrates that trepanation wasn't performed only on young, robust individuals but also on older people when circumstances warranted. One Greek skull from classical times shows a beautifully circular trepanation opening with edges that are almost perfectly smooth and even. The surgical skill demonstrated is remarkable. The hole looks like it could have been created with modern equipment. This skull represents the refinement that trepanation techniques could achieve in cultures with advanced medical traditions. A collection of skulls from medieval Russia shows interesting variation in trepanation methods. Some openings were created by drilling multiple small holes in a circle and then breaking out the bone between them. Others show scraping techniques. Still others appear to have been cut with saws. This variation within a single population suggests either multiple surgeons with different training or evolution of techniques over time. One particularly poignant example is a child's skull showing trepanation performed at a very young age, perhaps 2 or 3 years old based on skull development. The opening shows healing, indicating the child survived the procedure and lived at least some time afterward. The reason for trepanning such a young child can only be speculated, perhaps severe head trauma, perhaps congenital problems, perhaps seizures. The image of a toddler undergoing trepanation is deeply affecting, highlighting the desperate circumstances that could make such surgery seem necessary. Several skulls show what appear to be practice cuts, shallow grooves that don't penetrate the skull completely. These might represent teaching moments where experienced surgeons demonstrated technique to students using cadaver skulls, or perhaps their abandoned attempts where the surgeon began the procedure but stopped before completion. These practice marks remind us that trepanation knowledge was transmitted through training and apprenticeship, with skills developed through observation and supervised practice. When things went wrong. Not all trepanations were successful, and examining the evidence of failures helps us understand the procedure's risks and limitations. Some skulls tell stories of surgeries that went terribly wrong, providing cautionary tales from the distant past. Some skulls show multiple trepanation attempts in close proximity, with none showing healing. This suggests a patient who was subjected to repeated surgical attempts as they were dying or recently dead. Perhaps the first attempt failed to help, prompting a second, then a third in desperation. Or perhaps these multiple holes were created during or immediately after death as the surgeon tried to understand what had gone wrong or practice technique on a body that was already lost. Certain skulls show irregular, jagged openings suggesting the surgery was not going according to plan. Perhaps the bone fractured unexpectedly. Perhaps the patient moved at a critical moment. Perhaps the surgeon lost control of the cutting tool. Whatever caused these irregular openings, the lack of healing on their edges tells us the patient didn't survive long enough for recovery to begin. Some skulls display obvious damage to the inner surface, gouges, scratches, or fractures extending beyond the intended opening. This suggests the surgeon penetrated too deeply or lost control, damaging the dura mater or brain tissue beneath. Such damage would likely cause immediate complications, bleeding, brain injury, seizures, that proved fatal. These skulls serve as evidence of how little margin for error trepanation allowed. Certain examples show signs of infection, porous, degraded bone around the trepanation opening indicating the surgical site became infected before death. Postmortem bone changes are different from these perimortem infectious changes, allowing researchers to identify cases where infection was developing as the patient died. These skulls document infection as a major complication that ancient surgeons couldn't effectively combat. A few skulls show what appear to be abandoned procedures, openings that are started but not completed, with death occurring while surgery was still in progress. Perhaps the patient went into shock. Perhaps they began seizing. Perhaps they simply died from the trauma. The surgeon stopped mid-procedure, and the patient never regained consciousness. These incomplete trepanations represent the most dramatic failures, where the surgery itself proved immediately fatal. Medieval medical trepanation. As we move from ancient to medieval times, trepanation transformed from a practice passed down through oral tradition into a procedure documented in written medical texts. Medieval and Renaissance physicians inherited knowledge from ancient Greek and Roman medicine while adding their own observations and techniques. The ancient physician Hippocrates, writing around 400 BCE, included instructions for trepanation in his medical texts. He described when the procedure was appropriate, primarily for depressed skull fractures where bone fragments pressed on the brain. He provided detailed technical instructions about how to perform trepanation safely, warning against penetrating too deeply and advising on postoperative care. These writings were preserved and transmitted through the centuries, becoming foundational texts for medieval medical education. Medieval European surgeons learned trepanation as part of their training. Medical schools in cities like Salerno, Bologna, and Paris taught surgical techniques including skull surgery. The procedure was considered an advanced skill, something that distinguished trained physicians from common healers or barber surgeons. Only those with proper education and authorization were supposed to perform trepanation, though enforcement of these restrictions varied. The indications for medieval trepanation were primarily trauma-related. A knight struck on the head during battle, a worker injured in a construction accident, anyone suffering a depressed skull fracture might be candidates for trepanation. The surgeon would assess whether the injury warranted surgery, if bone fragments were pressing inward. If the patient was deteriorating despite other treatment, surgery might be attempted. Medieval surgeons also performed trepanation for chronic head conditions that didn't respond to other treatments. Severe persistent headaches, epilepsy, mental disturbances, these might prompt trepanation if the surgeon believed something physical inside the skull required release or removal. The theoretical framework was still based on humoral theory and the belief that diseases could be localized in specific organs or body parts. Monastic medicine played an important role in preserving and practicing surgical knowledge during the medieval period. Monks who served as healers in monastery infirmaries sometimes performed trepanation. They had access to ancient medical texts preserved in monastery libraries and could study surgical techniques described by Greek and Roman physicians. Some monasteries developed reputations for surgical skill, with patients traveling considerable distances to seek treatment from monk healers known for their abilities. The Arabic medical tradition, which preserved and expanded upon Greek medical knowledge during the medieval period, also included sophisticated approaches to trepanation. Physicians like al-Zarawi, known in the West as Albucasis, wrote detailed surgical manuals including sections on skull surgery. These Arabic texts eventually made their way into European medical education, enriching the Western surgical tradition. Renaissance surgical advances. The Renaissance brought new attention to anatomy and surgical technique, with trepanation benefiting from improved understanding and more sophisticated instruments. Andreas Vesalius, the great Renaissance anatomist, included detailed skull anatomy in his revolutionary 1543 work, De Humani Corporis Fabrica. His accurate illustrations of skull structure helped surgeons understand what they were cutting through and what lay beneath. Vesalius himself performed and taught trepanation, emphasizing careful technique and anatomical knowledge. Ambrose Pare, perhaps the most famous Renaissance surgeon, refined trepanation techniques and tools. Pare, who served as surgeon to several French kings, developed improved trepanning instruments and described multiple methods for opening the skull depending on the specific circumstances. His writings emphasized the importance of preserving the dura mater, the membrane protecting the brain, and provided techniques for working safely near this critical structure. Pare's trepanation set included specialized tools for different stages of the procedure. A sharp scalpel cut the scalp. A raspatory scraped away connective tissue from bone. A perforator or terebra made the initial hole through the skull. A trepan, a circular saw, enlarged the opening. A lenticular, a blunt probe, protected underlying membranes while the surgeon worked. Each tool had its specific purpose, and skilled surgeons learned when and how to use each one. The circular trepan, or crown trepan, was a major advancement over simple drilling. This cylindrical saw with teeth around its edge could cut a circular plug from the skull efficiently. A central pin positioned the trepan and prevented it from slipping during cutting. The surgeon would turn the handle, rotating the saw through the bone. This method was faster than scraping and created neat, circular openings. However, it also required considerable skill. The surgeon needed to sense when penetration was nearly complete and stop before damaging the dura. Surgeons developed techniques to prevent accidentally penetrating too deeply. Some placed a small cloth or sponge beneath the trepan as they worked, which would catch any breakthrough. Others relied on feel and experience, sensing the change in resistance as the saw neared the inner skull surface. The most skilled could stop within a paper's thickness of complete penetration, carefully breaking through the final thin layer with gentle pressure rather than sawing. Postoperative care in the Renaissance period was more systematic than in ancient times, though still limited by lack of knowledge about infection and wound healing. Surgeons applied various salves and dressings believed to promote healing. They monitored patients for signs of complications, fever, seizures, changes in consciousness. They provided instructions for rest and recovery, though the theoretical frameworks guiding these recommendations were still based on humoral medicine rather than modern understanding. When surgeons trepanned. Understanding the specific situations that prompted medieval and Renaissance trepanation helps us see how the procedure fit into the broader practice of medicine in these periods. Battle injuries were perhaps the most common indication. Medieval and Renaissance warfare produced abundant head trauma, sword cuts, mace blows, arrows to the head. A nobleman struck down in battle might be brought to a surgeon with a depressed skull fracture. If the injury seemed survivable but bone fragments pressed inward, trepanation might be attempted. The surgeon would cut around the injury, remove or elevate the depressed bone, and close the wound, hoping the patient would recover. Tournament injuries also led to trepanation. The elaborate martial competitions of medieval and Renaissance nobility were dangerous affairs despite armor and rules. A knight unhorsed and struck on the head might suffer skull fractures requiring surgery. Medical care at tournaments was sometimes quite sophisticated, with skilled surgeons present specifically to treat injuries. These tournament surgeons gained extensive experience with head trauma and trepanation. Falls and accidents in daily life caused head injuries that might require surgery. Construction workers falling from scaffolding, riders thrown from horses, people struck by falling objects, any of these could result in skull fractures. For working-class patients, the decision to undergo trepanation involved both medical and economic considerations. Could they afford surgery? Would they be able to return to work afterward? These practical concerns influenced whether surgery was pursued. Chronic conditions like epilepsy or severe mental illness sometimes prompted trepanation, though this was more controversial. Some physicians believed that opening the skull could release whatever caused seizures or madness. Others were skeptical that trepanation could help conditions not clearly related to visible skull injury. The decision to trepan for chronic conditions versus acute trauma represented a line between what we might consider legitimate medical intervention and speculative surgery based on flawed theory. The decline in Western medicine. By the 17th and 18th centuries, trepanation was becoming less common in Western medical practice, though it never disappeared entirely. Several factors contributed to this decline. Improved understanding of anatomy and physiology revealed that many conditions once thought to require trepanation didn't actually benefit from skull surgery. As medicine became more scientific, practitioners grew more cautious about invasive procedures that carried high risks without clear benefits. Trepanation for epilepsy or mental illness fell out of favor as physicians recognized these conditions weren't caused by problems that skull opening could address. The horrific infection rates made surgeons reluctant to operate except in the most desperate circumstances. Before antibiotics and aseptic technique, any surgery carried enormous risk of fatal infection. Brain surgery was particularly dangerous because infections of the brain and its coverings were almost always fatal. Surgeons weighed the near-certain risk of infection against the potential benefit of surgery and often decided the risks weren't justified. Alternative treatments became available for some conditions that had prompted trepanation. Better management of head trauma through rest and monitoring reduced the need for surgical intervention in some cases. Improved general medical care meant fewer people reached states of desperation where trepanation seemed worth attempting. The transition to modern neurosurgery. The decline of traditional trepanation in the 19th century coincided with the birth of modern neurosurgery, which borrowed the basic concept, opening the skull to access the brain, while transforming it through scientific understanding and sterile technique. The introduction of anesthesia in the 1840s revolutionized surgery generally and brain surgery specifically. Ether and chloroform allowed surgeons to operate on unconscious patients who felt no pain and remained perfectly still. This transformed what was possible. Surgeons could work carefully and precisely without rushing to complete procedures before patients' endurance gave out. Complex brain operations that would have been impossible on conscious, suffering patients became feasible. Joseph Lister's development of antiseptic surgical technique in the 1860s addressed the infection problem that had plagued surgery for centuries. By using carbolic acid to sterilize instruments and surgical sites, Lister dramatically reduced infection rates. This made elective surgery safer and justified operating in cases where the risk-benefit calculation had previously favored conservative treatment. Brain surgery, previously almost suicidally dangerous due to infection risk, became survivable. Improved anatomical knowledge allowed surgeons to target specific brain regions and address particular problems. Rather than simply opening the skull and hoping for the best, 19th-century surgeons could localize tumors, abscesses, or injuries and plan surgical approaches to address specific pathology. Brain surgery became rational and targeted rather than empirical and hopeful. The development of specialized neurosurgical instruments made delicate brain operations possible. Fine scissors, specialized retractors, gentle suction devices, precise cutting tools, these allowed surgeons to work on brain tissue without causing excessive damage. The crude tools of earlier trepanation gave way to sophisticated instruments designed for the brain's delicate structure. Harvey Cushing, often called the father of modern neurosurgery, established brain surgery as a distinct medical specialty in the early 20th century. Cushing developed techniques, trained surgeons, and demonstrated that brain operations could be performed safely and effectively when done by specialists with proper training and equipment. His work transformed neurosurgery from a desperate last resort into a legitimate therapeutic intervention. Trepanation's persistence. While trepanation declined in Western medicine, it persisted in various forms and places, continuing into the modern era in ways that connect ancient practices to contemporary times. Some indigenous cultures maintained traditional trepanation practices into the 20th century, performing the procedure as their ancestors had for generations. In remote areas where Western medicine hadn't penetrated, traditional healers continued using ancient techniques to treat head injuries and other conditions. These traditional practitioners possessed knowledge passed down through generations, knowledge that was oral and experiential rather than written or formal. Anthropologists studying these cultures documented trepanation procedures, creating records of techniques that might otherwise have been lost as traditional practices gave way to modern medicine. These ethnographic accounts provide valuable insights into how ancient trepanation might have been performed and understood by those who practiced it. In some cases, traditional and modern medicine coexisted, with people seeking trepanation from traditional healers for conditions they believed Western medicine couldn't address. This medical pluralism reflected different explanatory frameworks for disease, traditional beliefs about spirits or humoral imbalances versus biomedical models of pathology. The survival of trepanation in traditional contexts reminds us that medical practices persist as long as they serve functions their communities value, regardless of whether those practices align with scientific understanding. For cultures where trepanation carried spiritual significance or formed part of healing traditions, abandoning it would mean losing more than just a medical technique. Reflections and closing. As we reach the end of this first hour exploring trepanation's history, let's reflect on what this ancient practice reveals about human nature, suffering, and the drive to heal. Trepanation demonstrates both the desperation and the ingenuity that suffering inspires. When people hurt badly enough, when conditions seem unbearable, when death threatens, the idea of boring through someone's skull with Stone Age tools becomes not insane but reasonable. The practice persisted because sometimes it helped, because the alternative was continued suffering or death, and because humans would rather try something than passively accept fate. The skill involved in ancient trepanation commands respect. Surgeons working with stone or bronze tools, without anesthesia or antiseptics, achieved survival rates that seem impossible yet are documented in bones that don't lie. They developed techniques, trained successors, refined their craft across generations. They were healers doing the best they could with available knowledge and tools, and often they succeeded. The patients who endured trepanation, conscious, feeling every moment, hearing their own skulls being scraped open, displayed extraordinary courage or experienced extraordinary desperation. Perhaps both. Their survival speaks to human resilience, to the body's capacity to heal even from severe trauma, to the will to live that sustains people through ordeals we can barely imagine. As you drift toward sleep, perhaps you'll think about the thousands who underwent trepanation across history. The frightened patient lying still while hours of scraping wore through their skull. The surgeon concentrating intensely, knowing any error might prove fatal. The family members watching, hoping, praying. All of them dealing with suffering and death using the tools and knowledge their time and culture provided. In our second hour, we'll explore how trepanation survived into modern times in unexpected ways, not as legitimate medicine but as fringe practice among people who believe drilling holes in their skulls will expand consciousness. We'll examine the modern trepanation movement, meet those who have voluntarily undergone the procedure, and consider what this ancient practice means today. But for now, rest. Let yourself settle into sleep, knowing that the trepanned skulls lying in museums and archaeological collections represent real people who lived and suffered and sometimes survived the opening of their skulls. Their bones tell stories of pain and healing, of death and survival, of human attempts to understand and address the mysteries within our own heads. Sleep well, and may your dreams be gentle. The journey through trepanation continues in part 2, but for now, simply rest. Good night.